Hi, my name is Ana Belén Zúñiga and I'm going to talk about Cabozantinib versus Everolimus in advanced renal cell carcinoma. Cabozantinib is an oral small molecule tyrosine kinase inhibitor that targets vascular endothelial growth factor receptor, as well as MET and AXL, each of which has been implicated in the pathobiology of metastatic renal cell carcinoma or in the development of resistance of anti-angiogenic drugs.
The following is a CT scan of the abdomen and pelvis performed with intravenous contrast. We'll start at the lung bases and scroll inferiorly. As you scroll inferiorly, we can see that there is an exophytic, predominantly solid mass arising from the upper pole of the left kidney, compatible with a renal cell neoplasm. There is an additional mass in the left kidney seen more inferiorly. However, if we observe its density value, and in fact measure its density value by putting a Hounsfield unit over this, we'll see that it measures simple fluid, somewhere between -20 and 20 Hounsfield units, thus indicating that it reflects a simple cyst. As we scroll through the right kidney, we can see that in the interpolar to lower pole region, there's another simple cyst. However, there are no solid masses arising from the right kidney to suggest a renal neoplasm. On these images, we can observe some of the vasculature associated with the kidneys. On this image, this is the aorta, this is the IVC. As you scroll downwards, we can start to see the left renal vein, and notice how the left renal vein travels anterior to the abdominal aorta as it joins the IVC. We can also start to see both renal arteries, right side and left side, and we can follow these vessels to the kidneys. This vessel over here is the gonadal vein, which on the left almost always drains into the left renal vein. We can follow this as we scroll upwards again. We can also see the collecting systems, which join to form the renal pelvis, and subsequently the ureters as they course inferiorly to the pelvis. This is a coronal CT scan of the same case. We're going to be scrolling from posteriorly to anteriorly in this case. So as we go from posterior to the anterior, the posterior-most structures, we're going to start to see the spine, some of the ribs, some of the bones, and then we'll start to see the kidneys. Once again, you can see an exophytic, predominantly solid mass arising from the upper pole of the left kidney, compatible with a renal cell neoplasm. On this image, you can see some of the left collecting systems, which will join to form the left renal pelvis. As we scroll, we can also see the left renal artery, as well as the left renal vein, which drains into the inferior vena cava.
Applications in medicine. MET and AXL are upregulated in renal cell carcinoma as a consequence of VHL inactivation, and high expression of each is associated with poor prognosis.
I had the opportunity to participate at the Ipsen Satellite Symposium in Kidney Cancer, together with my colleagues Dr. Bernard Scudder, Dr. Tom Pauls, and Dr. Tony Chueri. And my task at that Satellite Symposium was to translate the data that we have, the clinical report of the phase 3 trial, the Meteor trial with Cabozantinib, and the Checkmate 025 trial with nivolumab, how we can translate that into selecting our treatment for patients in second line after failure to one prior tyrosine kinase inhibitors. At that moment, we presented 3 different clinical cases, and in this clinical case, we show different profiles of patients who were candidates to one or the other alternatives. Unfortunately, in this field, we don't have a biomarker, a predictive molecular biomarker that really can help us in the daily clinical practice. So we need to base our treatment decisions in things in factors like patient characteristics, age, comorbidity, co-medications, or in tumor characteristics, how bulky is the tumor, what is the tumor burden, how fast the tumor is progressing, and of course, the tolerability and the clinical outcome to the first line the patient receives. So I really hope the attendees, well, at least they thought twice about what they are doing in their practice.
Approximately one-third of patients present with metastatic disease at diagnosis, and in about one-third of treated patients with localized disease, the disease will relapse.
So the work presented at ASCO around the treatment of sarcomatoid renal cell carcinoma is most exciting. So sarcomatoid is a form of differentiation that can occur from clear cell as well as non-clear cell histologies. Most of the studies that are being presented are focusing on the clear cell tumors, but there is a consistent trend that pretty much cuts across the regimen, whether it be nivolumab and ipilimumab, or whether it be pembrolizumab and axitinib, or whether it is a combination of that is not going forward clinically, the combination of bevacizumab together with atezolizumab. The data seems to show that all of these IO-containing regimens are regimens that increase the response rates and the progression-free survival and the overall survival for patients with sarcomatoid tumors. This is particularly important because traditionally the survival of these patients has been rather poor. Sarcomatoid tumors do not respond well to traditional targeted therapies, and the median overall survival for these patients has traditionally been less than a year. So these IO-containing regimens are making really a big difference in this patient population. Now, the studies that are being presented are still in largely the exploratory phase. In the pembrolizumab axitinib study, looking at the sarcomatoid population was one of the pre-specified secondary endpoints, but in the case of the CheckMate 214 trial of nivolumab and ipilimumab, this is unspecified post-hoc analysis, and in the case of bevacizumab and atezolizumab, this combination is not going forward, so it's not going to be available for patients. But nonetheless, I think given the consistency of all of the data, it is quite likely that there is a signal there, and that this patient population, which represents an unmet medical need, is likely to benefit from IO-containing regimens.
Renal-cell carcinoma is the most common form of kidney cancer, with more than 3,300 cases diagnosed and more than 100,000 deaths attributed to it worldwide every year.
The treatment of renal cell carcinoma has changed considerably in the past several years. When we think back to the initiation of therapy, we had TKI therapy as the mainstay with sunitinib, pazopanib, and after that there were several other TKIs you could use afterwards. But really the sequencing was unclear and pro-inhibition TKI. Then we had the pivotal METEOR trial and CheckMate 2.5 done at the same time, showing that both cabozantinib and nivolumab offered us improvement in overall survival in the second-line setting. And so that led to a pattern of care where patients would start with a TKI, go on to receive cabozantinib, and then nivolumab, or vice versa. They would go on TKI, nivolumab, and then cabozantinib. And now, as we look at things evolving, the role of immunotherapy is really moved to the front line with nivolumab, ipilimumab approved in the United States, front line for those with intermediate poor risk disease. And we've just heard data on the combination of axitinib and Everolimus showing marked improvement in response rates, PFS, with a press release for pembrolizumab showing improvement in overall survival in the frontline setting compared to sunitinib. So clearly immunotherapy is moving into the front line. And so one of the dilemmas we face is with cabozantinib being studied in VEGF refractory, does prior immunotherapy really, does it affect the activity of cabozantinib? And so that's unlikely to be studied prospectively. We did a retrospective review between ourselves and Emory of 86 patients who had received immunotherapy as the most recent line of therapy and then went on to receive cabozantinib. And what we showed overall is that the activity of cabozantinib was preserved. So by investigator-assessed response, 36% of patients achieved a partial response, with 79% deriving clinical benefit, either stable disease or partial response, with a median time to treatment failure of over 6 months. So I think there's a lot of subgroup analysis that we've discussed in detail on our poster. I think the main takeaway is that in the setting of prior immunotherapy, cabozantinib continues to have an important role and will continue to have a role in the second-line therapy for our patients with metastatic renal cell carcinoma, and just gives us another definitive option for our patients in that situation.
Progression-free survival was longer with cabozantinib than with Everolimus among patients with renal cell carcinoma that had progressed after VEGFR target therapy.
I'm Bill Breaux, reporting from Southwest Florida. The United States Food and Drug Administration has approved a new treatment for patients living with advanced renal cell carcinoma. Cabozantinib tablets for the treatment of patients with advanced renal cell carcinoma who have received prior anti-angiogenic therapy were approved and granted Fast Track and Breakthrough Therapy designations by the FDA. This is the first therapy to demonstrate in a phase 3 trial for patients with advanced renal cell carcinoma robust and clinically meaningful improvements in all 3 key efficacy parameters: overall survival, progression-free survival, and objective response rate. The brand name of this new FDA-approved therapeutic is Cabometyx.